You brush and floss, you rinse, and still, by mid-morning someone leans away, or you catch a glimpse of your own reflection and worry. That familiar frustration is real. But before you assume the worst or buy another bottle of mouthwash, try 5 morning habits that you can start today. These are practical, low-risk steps that often reduce morning breath and, importantly, give you clues about where the smell is coming from so you know whether to manage at home or see a clinician. If this resonates, type 1 in the comments and subscribe so you don't miss the hands-on demo linked below. First, a quick primer so the steps make sense. Bad breath, or halitosis, usually isn't a moral failing, it's a biological process. Your mouth is a warm, moist ecosystem where many bacteria live. Some bacteria produce volatile sulfur compounds, or VSCs, small, smelly molecules that smell like rotten eggs, garlic, or sewer gas. Others produce different smelling compounds that can be fruity or musty. Brushing your teeth cleans surfaces, but it doesn't reach every nook where bacteria and debris collect. Hidden reservoirs, the tongue's rear surface, deep pockets next to gums, the undersides of dental restorations or appliances, and the crypts of the tonsils can continue to seed odor even after you brush. Because multiple niches can contribute at once, a 2-part approach works best. First, adopt a few reliable morning habits that reduce the bacterial load and improve saliva flow. Second, do simple checks to narrow the likely source. That way your morning routine both treats and teaches. You're reducing smell right away and collecting useful information if the issue persists. 3 fast checks that take less than 2 minutes can tell you a lot. The first is a tongue scrape smell test. Use a tongue scraper or the edge of a clean teaspoon. With a single firm but gentle sweep from back to front on the middle third of the tongue, move visible coating forward and inspect, and optionally, smell the scraper briefly. If the scraper has a distinct sulfurous or rotten egg odor, the tongue is often a major contributor. A coated white or yellowish tongue that produces a strong smell on the scraper suggests bacterial coating is high on the list. The second is the interdental or gauze smell test. Run floss or an interdental brush between a few teeth, ideally where food tends to lodge, or take a clean, dry piece of gauze and rub it gently along the gum line and around crowns or bridges. Smell the floss or gauze. If the odor is stronger from between teeth than from the tongue, periodontal pockets or trapped debris around restorations may be the main source. Deep, persistent pockets often harbor anaerobic bacteria that make potent VSCs. The third is a visual tonsil check. With a bright light and a mirror, say ah and look toward the back of the throat.
Tonsil crypts are the small pits or folds on the tonsils. They can collect bacteria and debris, sometimes forming small white or yellowish collections called tonsilloliths or tonsil stones. If you see visible stones or heavy debris and the smell seems to come from the back of the throat rather than the mouth surface, tonsils or postnasal drip may be involved. Never attempt sharp or forceful removal at home. Gentle saline gargles can help dislodge soft material, and persistent or symptomatic stones are best evaluated by an ENT. Put those 3 quick checks together and you have a triage map. If the tongue scrape is the most odorous, start your morning routine focused on tongue hygiene and hydration. If interproximal floss shows the worst smell, emphasize interdental cleaning and book a dental check for possible periodontal disease. If tonsil debris or a deep throat smell predominates, include saline gargles and consider an ENT evaluation if it's recurrent or bothersome. These checks are not definitive diagnoses, but they're practical signals to guide the next steps. Now for the 5 morning habits, the heart of this routine. Each habit is designed to be repeatable, safe, and informative. You'll both reduce odor and gather data about what's helping. We'll go deep on technique, common mistakes, safety notes, and how quickly you might notice a difference. Habit 1. Gentle tongue scraping every morning. The back of the tongue has many papillae and crevices where bacteria, dead cells, and food residues collect. A coated tongue is one of the most common and treatable sources of morning breath. A tongue scraper removes that coating more effectively than a toothbrush alone. How to do it? Lean slightly forward, stick your tongue out, place a flexible tongue scraper as far back on the middle third of the tongue as you comfortably can, and pull forward in one smooth motion toward the tip. Rinse the scraper and repeat 2 to 3 times, concentrating on the middle to posterior surface rather than the very tip. Finish with a gentle brush of the tongue with a toothbrush if desired. Rinse your mouth with water or a mild salt rinse. Why it helps? Removing surface coating reduces the biomass of bacteria producing VSCs. Scraping also removes malodorous debris that toothbrush bristles often miss. Common mistakes and variations: pressing too hard can cause gagging, irritation, or minor abrasions. Keep pressure moderate.
Scraping only the tip of the tongue missed most of the problem. Disposable tongue cleaners and U-shaped plastic scrapers are fine. Some people prefer stainless steel scrapers that are easy to sanitize. For people with a strong gag reflex, start with very short strokes on the anterior tongue and gradually work further back as tolerated. If you wear braces, clear aligners, or a fixed retainer, you can still scrape. Work around orthodontic hardware gently and avoid dislodging components.
Safety notes. If you see significant bleeding, painful ulcers, or new persistent taste disturbances, pause scraping and consult your dentist or physician. Tongue scraping is generally safe, but do not use sharp instruments or objects to pick debris. Clean your scraper after each use with warm water and soap, and replace it if it becomes nicked or rough. Expected timeline. Many people notice a reduction in odor within 24 to 48 hours of consistent scraping. For some, improvements continue over a week as the coating thins and bacterial populations shift. If scraping reduces odor substantially, the tongue was likely a dominant source. Habit 2. A measured saltwater gargle each morning. A simple warm saline rinse soothes tissues, helps loosen sticky debris from the back of the throat and tonsils, reduces bacterial load transiently, and promotes comfort. It's not a cure for deep infections, but as a morning habit, it can materially reduce malodor, particularly when tonsillar debris or postnasal drip contributes. How to do it? Dissolve about half to a full teaspoon of table salt in an 8-ounce glass of warm, not hot, water. Take a comfortable mouthful, tilt your head back slightly, and gargle for 10 to 15 seconds without swallowing. Spit and repeat twice more. You can also swish the saline around the mouth first to loosen oral debris before tilting back to gargle. Why it helps? Salt water creates a mild osmotic gradient that reduces tissue swelling and can help dislodge mucus and debris from crypts in the throat. The warmth and mechanical action of gargling also flush material that might be producing odor. Salt has a modest antimicrobial effect when used as a rinse, but it is not a substitute for professional treatment of infections. Common mistakes and alternatives. Using too much salt makes the rinse uncomfortable. Baking soda, 1/2 teaspoon baking soda in 8 ounces of water, can be an alternative for neutralizing odors and reducing acidity, particularly after reflux episodes, but it should be used occasionally rather than daily if you have a sodium-restricted diet. Avoid long-term reliance on strong antiseptic mouthwashes unless directed by a clinician. Alcohol-containing mouthwashes can dry the mouth and paradoxically worsen odor for some people, and chlorhexidine wipes down bacteria broadly, but has downsides with long-term use such as taste alteration and staining. Safety notes. Do not swallow the rinse. If you have strict sodium restrictions for medical reasons, check with your primary care clinician before starting daily saline rinses. If gargling triggers severe coughing, breathlessness, or recurrent aspiration, stop and consult a clinician. Expected timeline. If tonsillar or pharyngeal debris contribute significantly, you may notice less back of the throat smell within 24 to 48 hours of consistent morning saline rinses.
For persistent tonsillitis or chronic postnasal drip, saline may provide symptom relief but not full resolution, and an ENT evaluation may be warranted. Habit 3. Hydration on waking and purposeful stimulation of saliva. Glass of water plus sugar-free xylitol gum after breakfast. Saliva is the mouth's natural cleansing fluid. It contains enzymes, antibodies, and mechanical flow that dilute and clear bacteria and their byproducts. Overnight, saliva flow declines and the mouth becomes drier, which is why morning breath is common. Rehydrating immediately upon waking and stimulating saliva after eating are simple, effective steps. How to do it? Keep a glass or bottle of water bedside and sip a full glass within 10 minutes of waking. Avoid drinking large amounts of caffeinated beverages immediately on an empty stomach if they make you feel dehydrated. Start with water first. After breakfast, chew sugar-free gum containing xylitol for 10 to 20 minutes to increase salivary flow. Xylitol also reduces certain karyogenic bacteria and can lower the risk of cavities. It may have modest benefits in reducing odor by changing the oral bacterial environment. Why it helps? Increasing saliva flow reduces the concentration of VSCs, mechanically washes away debris, and supports mucosal health. Saliva's enzymes help break down volatile compounds and limit bacterial overgrowth. Common mistakes and considerations. Chewing gum immediately after vigorous exercise or on an empty stomach can cause discomfort for some people. Choose sugar-free formulations. Avoid gum for young children under age 4, and check ingredient restrictions if you have dietary or metabolic rules. Not all sugar-free gums are equal. Xylitol-containing gums have more evidence for oral health benefits than sorbitol-only gums. Safety notes. People with xerostomia, chronic dry mouth, due to medications should not stop prescribed medications. Instead, document dry mouth symptoms in your log and discuss alternatives with your prescriber. For those with temporal mandibular joint, TMJ disorders, limit gum chewing to short intervals to avoid exacerbating jaw pain. Expected timeline. Improved hydration can reduce the intensity of morning breath within hours.
Routine hydration combined with post-meal xylitol chewing often shows noticeable improvement within 2 to 7 days. If saliva stimulation makes little difference because tissues remain chronically dry, medication-induced dry mouth or systemic conditions may be contributors that need clinician review. Putting the first 3 habits into your AM routine is straightforward. A suggested sequence you can try today: sip a glass of water on waking, then perform a gentle tongue scrape, follow with a saltwater gargle, brush and floss as usual, and after breakfast, chew sugar-free xylitol gum for 10 to 15 minutes.
That sequence treats multiple reservoirs at once and gives you baseline data. If the tongue scrape smelled strongly before habit 1, but less so after 3 days, the tongue was likely a key contributor. If interdental smell persists despite interdental cleaning, periodontal disease may be a culprit. A simple log will add power to this routine. Keep a notebook or a simple note on your phone and record the date, a morning breath score from 1, no noticeable odor, to 10, very strong, which of the 5 habits you completed, any noteworthy foods the evening before, garlic, onions, alcohol, any new medications, and the results of the 3 quick checks: tongue scraper, low, moderate, high; floss gauze, low, moderate, high; tonsil visual, clear, debris, visible stones. After 48 hours, you'll have 2 data points. After 2 weeks, you'll see trends that can inform whether to continue conservative care or pursue professional evaluation. To illustrate how these early habits and a short log can play out, consider Anya. She is in her late 20s, generally healthy, and embarrassed by persistent morning breath despite daily brushing. On day 1, her tongue scraper smelled strongly, and she rated her morning breath a 7 out of 10. She began the 3-step routine: water on waking, gentle tongue scraping, and a saltwater gargle before brushing. She also started logging meals and whether she completed each habit. Within 3 days, Anya's morning breath rating dropped to 4, and the scraper smell decreased to moderate. After a week, with consistent scraping and hydration, Anya's rating hovered around 2 to 3 most mornings. The log helped her see that when she skipped scraping after late-night snacking, her rating spiked again, pointing to the tongue as the primary driver. She used this information to prioritize daily scraping and to schedule a routine dental check to confirm there were no periodontal pockets or restorative issues. Anya's case shows that for many people, a focused morning ritual addresses a dominant source of odor and clarifies when professional input is necessary. Deepening our understanding of the most common reservoirs helps explain why these habits work and what to expect if they don't. Start with the tongue. The dorsal, top surface, has filiform papillae that trap soft debris and microbes. Different coatings, white, yellowish, or brown, can reflect bacterial biomass, recent food pigments, or dry mouth. Tongue coating that produces a strong sulfurous smell often responds quickly to mechanical reduction, scraping and brushing, because the offending microbes live right on that surface. Overgrowth patterns can shift with diet, medications, sleep habits, and systemic conditions. For example, low-carbohydrate diets that induce ketosis may give breath a fruity or acetone-like quality that is less responsive to tongue scraping alone. In such cases, hydration and addressing dietary patterns matter. Periodontal niches are different.
Periodontal pockets are spaces that develop between the tooth and gum when support structures are compromised. They create anaerobic environments where certain bacteria thrive and produce particularly potent VSCs. If the interdental floss or gauze smell test is strongly positive, or if you notice bleeding on flossing or persistent bad taste, periodontal disease may be a contributor. These pockets generally require professional cleaning, sometimes deeper scaling and root planing, and ongoing maintenance. Home care is critical, but is rarely a substitute for clinical therapy in established periodontitis. Restorations and appliances deserve attention too. Crowns, bridges, poorly fitting dentures, and orthodontic hardware can trap food and bacteria. Small ledges or gaps around margins are invisible to a toothbrush, but will show up on a gauze or floss smell test. If you wear fixed dental work and smell is localized around those areas, schedule a dental evaluation. Often, correction of marginal defects or improved professional maintenance reduces odor significantly. Tonsil crypts and tonsil ellipses are common but often under-recognized. When debris collects in tonsillar crypts and hardens into stones, they can produce a distinct back-of-throat smell. Some tonsil ellipses are small and asymptomatic. Others cause persistent bad breath, foreign body sensation, or throat discomfort. Gentle saline irrigation and gargling can help dislodge soft material, but hard or recurrent stones and related symptoms are best managed by an ENT. Remember, never use sharp tools or aggressive probing at home. That risks tissue injury and infection. ENT evaluation may include visual inspection, possibly imaging for large stones, and discussion of options ranging from conservative removal to surgical approaches in refractory cases. As you put habits 1 through 3 into practice, be mindful of a few cautions. If new bleeding occurs when you start more vigorous flossing or tongue scraping, note it in your log and consult your dentist. Occasional light bleeding with aggressive or previously irregular flossing is common, but continuing heavy bleeding or associated pain requires evaluation. If you experience severe throat pain, fever, weight loss, or difficulty breathing, seek urgent care. Those are red flags outside the scope of routine halitosis management. Common questions come up quickly. Is tongue scraping safe with braces? In most cases, yes. Use a flexible scraper and be cautious around brackets. Rinse after each pass and avoid lifting or tugging at orthodontic hardware. How often should I replace a toothbrush? Replace it every 3 months or sooner if bristles fray, and after an illness. Is mouthwash enough? Mouthwash can be a helpful adjunct, particularly alcohol-free, low-irritant rinses used short-term, but it often masks rather than fully treats sources like periodontal pockets or tonsillar debris.
Watch for products with chlorhexidine. They can be effective for short-term control, but are not intended for indefinite daily use because of taste changes and staining. Follow a clinician's guidance. By now, you're well into building a morning habit loop. Wake, hydrate, scrape, gargle, brush, floss, and then stimulate saliva with xylitol gum. These actions treat multiple likely sources simultaneously, reduce VSC formation, and create diagnostic signals you can log and interpret. Over the next 48 hours, you should see directional change if the cause is one of the more responsive reservoirs, particularly the tongue. If 3 days in you see no improvement, the source may be deeper: periodontal pockets, problematic restorations, ENT-related mucus, or systemic contributors, and that's where a short diagnostic trial and timely escalation come into play. We've covered the first 3 habits in depth because they address the most frequent and treatable causes of morning breath and because they give you immediate feedback. Habit 4 and Habit 5 are practical behaviors that tie the routine together and increase long-term success. Habit 4 is about thorough interdental cleaning as an integral part of your AM routine. Habit 5 is the morning inspection ritual, performing the 3 quick checks and updating your log so you can turn subjective impressions into objective data. Before we get into those final 2 habits and a detailed 48-hour diagnostic trial, it's useful to explore a few more nuances about technique and troubleshooting that people often overlook. Technique nuance number 1. Timing matters. Performing saline gargles and tongue scraping before brushing can remove loose material and allow toothpaste to reach cleaner surfaces, improving overall effectiveness. However, if you prefer to brush first, follow immediately with scraping and gargling. Consistency is what matters most. Nuance number 2. Don't overdo antiseptic rinses. Short courses of an alcohol-free antimicrobial rinse can be helpful for acute flares, but frequent long-term use of potent antiseptics can disrupt the oral microbiome and cause side effects. If you find yourself rinsing multiple times daily for weeks without improvement, note that pattern and bring it to a clinician's attention rather than escalating dose and frequency on your own. Troubleshooting scenario. You followed habits 1 through 3 diligently for a week, but notice only minor improvement. Your log shows that tongue scraper smell decreased, but floss/gouge smell remained high. That pattern raises the index of suspicion for periodontal disease or issues around restorations. The next pragmatic step is to maintain your morning habits and schedule a dental appointment, bringing a copy of your log and a concise script that states the problem and what you've tried. A simple, factual script might read, "I've had persistent bad breath for X weeks. I've been doing twice daily brushing, daily interdental cleaning, daily tongue scraping, and saline gargles. I documented my scores and noted that interdental sites remain odorous. Could you evaluate for periodontal pockets and check my restorations margins?" Giving your clinician this structured information speeds appropriate assessment. Before we pause to continue with habits 4 and 5 and the full 48-hour diagnostic protocol, let's consider one more brief vignette that highlights less common contributors. Marcus is in his late 40s and has a history of sleep apnea with nightly CPAP use. He noticed a persistent morning dryness and a musty breath that didn't improve much with tongue scraping. His log revealed that mornings after particularly dry nights were worse. A review with his PCP and dentist showed that mask fit and humidification levels affected his oral dryness. Adjusting humidification and ensuring a well-fitted mask reduced daytime dryness and improved breath in combination with the other morning habits. Marcus's case reminds us that devices, sleep patterns, and systemic issues can influence oral environment, and that the morning routine often needs to be coordinated with other aspects of healthcare. At this point, you have 3 powerful, evidence-framed habits in place and a simple system to collect data. The next steps are twofold. Add the remaining 2 morning habits that complete the routine, and begin a structured 48-hour diagnostic trial to see which interventions move the needle most.
We'll get into detailed step-by-step instructions for the diagnostic trial, an expanded 2-week plan, and deeper dives into periodontal, restorative, ENT, and systemic causes, plus clinician scripts you can copy into appointment requests in the next section. For now, reinforce the first 3 habits today and keep the log. The pattern you record will be the single most valuable tool you bring to any clinician if you need one. Habit 4 is thorough interdental cleaning as a non-negotiable part of your morning routine. Many toothbrushes, manual or electric, do an excellent job on visible tooth surfaces, but the tight spaces between teeth and along margin interfaces are where food, plaque, and bacteria hang on. Those trapped microbial communities are efficient producers of volatile sulfur compounds, and cleaning them out each morning both reduces odor and gives you a clearer sense of whether deeper problems are present. How to make interdental cleaning reliable and comfortable. Choose the right tool, learn the right motion, and be consistent. If you have tight contacts, traditional floss, waxed or unwaxed, will often be the most practical option. The recommended technique is to slide a length of floss gently between the teeth, curve it into a C shape against one tooth, press it against the surface, and move it up and down 2 to 3 times, then repeat on the adjacent tooth surface.
Avoid snapping the floss down into the gum. Gentle, controlled pressure protects soft tissues. If flossing causes heavy bleeding that doesn't settle after a week of regular, gentle flossing, note it in the log and see your dentist. Persistent bleeding can signal gingivitis or periodontitis needing professional care. Interdental brushes are excellent when spaces are slightly larger or when you have fixed prostheses, exposed root surfaces, or orthodontic brackets. They come in sizes. Select the smallest brush that fits snugly without forcing. Insert it parallel to the biting surface, slide it in and out a few times, and rinse it after use. Overzealous use with a brush that's too large can irritate the gums. Underuse with a brush that's too small won't be effective. If you're unsure what size to use, bring a sample to your dentist and ask for sizing guidance during a routine visit. Water flossers are another option, particularly for people with dexterity challenges or certain periodontal conditions. Used properly, they can reduce food debris and disrupt biofilm in shallow pockets, and many people find them easier to integrate into a daily routine. They're not a universal substitute for mechanical interdental cleaning in deeper periodontal disease, however. If you choose a water flosser, start on a lower pressure setting and sweep the tip along the gum line at a 45-degree angle for each tooth. Note any bleeding or discomfort and record it. For people with periodontal disease, a clinician will determine whether a water flosser is reasonable as part of a maintenance plan. Common mistakes to avoid with interdental cleaning: using the wrong size brush, forcing floss into extremely tight contacts without control, or assuming a quick pass replaces a careful, systematic approach. Consistency matters. Doing interdental cleaning only sporadically often provokes more bleeding and discomfort, while daily, gentle cleaning improves tissue health and reduces odor over weeks. Expected timeline: when interdental cleaning is the missing piece, you may notice a measurable reduction in morning breath over 1 to 3 weeks. Periodontal improvements and reduced pocket depth take longer and require professional scaling and continued home care. But the odor relief signal from daily interdental cleaning is often observable within several days to weeks. Habit 5 completes a disciplined morning inspection ritual. This is the habit that turns subjective worry into objective data and shortens the path to effective care. Spend 2 minutes each morning performing the 3 quick checks you practiced earlier: tongue scrape smell test, gauze floss smell test, and tonsil visual, and immediately update your log. Rate each test on a simple scale: low, moderate, high, or 1 to 10.
Note whether your morning breath score is better, worse, or the same compared with the previous day. Record any unusual foods, alcohol, changes in sleep, new medications or supplements, or appliance use: CPAP, night guards, retainer. Take a quick photo of your tongue or tonsils if you notice visible change. Images can help clinicians assess progression when you share them during an appointment. Keep the log accessible. A phone note, a small paper notebook, or a single spreadsheet will do. How to interpret small patterns: if your tongue scrape score drops, but floss/gauze remains high, that pattern favors periodontal or restorative issues. If the tonsil visual shows recurring debris and the smell is concentrated in the back of the throat, prioritize saline gargles and consider ENT evaluation if stones are recurrent. If your overall breath score improves on mornings when you hydrate and show xylitol after breakfast, saliva dynamics are probably an important factor. The inspection habit is less about perfection and more about collecting consistent signals that allow you and your clinician to make efficient decisions. The 48-hour diagnostic trial is a focused, practical experiment you can run starting today. It's deliberately short so you can detect rapid signals from responsive causes while minimizing interruptions to your usual life. Here's a step-by-step protocol you can follow and copy into your log.
Before you start, pick a 48-hour window when you can be reasonably consistent with sleep and diet. 2 consecutive mornings are ideal. Do not change prescription medications without discussing with your clinician. Instead, note current medications and any temporary over-the-counter products in the log. Day 0, baseline evening. Record your usual evening routine and last meal. Take a baseline morning breath score the next day before any oral activity, and perform the 3 checks to establish starting values. Photograph the tongue and, if possible, the back of the throat under a bright light. Day 1, first intervention morning. On waking, sip a full glass of water. Perform gentle tongue scraping, 2 to 3 sweeps, then do a warm saline gargle, about 1/2 to 1 teaspoon salt in 8 ounces warm water. Gargle for 10 to 15 seconds and spit. Repeat up to 3 times. Brush and floss/clean interdentally as usual, then continue with mixed hydration and after breakfast sugar-free xylitol gum for 10 to 15 minutes. Immediately after completing the routine, record a morning breath score and the 3 test ratings. Note any bleeding, pain, or gagging. Day 2, second intervention morning. Repeat the exact same morning sequence. Record scores and photos in the same manner as day 1. At the end of day 2, compare the baseline and 2 trial days. Look for directional change. Even a 1 or 2 point shift is meaningful. If tongue scraping produces the largest reduction and the tongue scrape smell rating drop most, the tongue is a likely major contributor.
If interdental scores remain high despite signal reduction on the tongue, periodontal or restorative issues warrant dental follow-up. If the back of throat ratings remain elevated, consider ENT review. What to do after 48 hours? If you see clear improvement across the board, maintain the routine and expand into the 2-week plan to consolidate gains. If you see partial response, tongue improved but other ratings persist, maintain the routine while scheduling a targeted dental or ENT evaluation with your log in hand. If there's no perceptible change and your baseline scores are high, escalate sooner rather than later. Persistent odor without trend suggests deeper reservoirs or systemic contributors. The optional 2-week plan builds on the 48-hour trial and is designed to give slower changing causes a fair trial while maintaining careful documentation. The 2-week schedule looks like this. Week 1. Keep the morning routine daily. Water on waking, tongue scraping, saline gargle, brushing, interdental cleaning, and xylitol gum after breakfast. Perform the inspection ritual and log every morning. If you notice bleeding initially when you begin interdental cleaning, continue gentle cleaning daily. Bleeding often diminishes with improved plaque control over the first week. If bleeding worsens or pain develops, pause extra force and consult your dentist. Week 2. Continue the routine but add one small variable if you and your clinician agree, such as a short clinician-guided course of an alcohol-free antimicrobial rinse for 7 days if your dentist suspects a high bacterial burden localized to pockets. Do not self-prescribe chlorhexidine for long-term use. It's best used under professional direction because of staining and taste changes. Continue morning logs and photos. At the end of week 2, summarize trends. Average morning breath score, highest and lowest values, and which test improved most. Decision points after 2 weeks. If you've had meaningful sustained improvement, e.g. average score drops by 3 or more points and stays lower most mornings, continue the routine and plan routine dental maintenance visits. If there's partial improvement, use your log to decide the next referral. Periodontal assessment for persistent interdental odor, ENT for persistent tonsillar back of throat odor, or PCP if systemic or metabolic clues exist, e.g. fruity bath, unexplained weight changes, or other systemic symptoms. If the problem is unchanged and your log shows consistently high scores, make a cross-specialty appointment pathway. Schedule a dental check including full periodontal charting and radiographs. And if dental evaluation is unremarkable, consult your PCP for further systemic workup, and consider ENT referral if throat findings persist. Now let's step through deeper profiles of the common odor reservoirs so you can recognize and respond to specific patterns.
Each section will list typical signs, likely smell characteristics, home measures that may help, and clear thresholds for professional referral. The tongue. Signs and typical smell. A coated, often white or yellowish posterior dorsum of the tongue that yields a sulfurous or rotten egg odor on scraping. People often report worse smell first thing in the morning and after nights of mouth breathing or reduced fluid intake. Why it's responsive? The microbes producing VSCs are sitting on an exposed epithelial surface. Mechanical removal reduces their substrate and population quickly. Saliva stimulation further dilutes and clears compounds. Home measures that help. Daily gentle tongue scraping as described, hydration on waking, saline gargles, brief brushing of the tongue after scraping, and attention to breath-promoting dietary triggers in the evening, garlic, onions, alcohol. Consider limited use of an alcohol-free mouthwash immediately after the morning routine if the smell persists. Choose low-irritant formulas and avoid long-term daily chlorhexidine with clinician oversight. When to see a clinician. If scraping causes persistent bleeding, ulceration, or intense pain, if taste disturbances develop or persist,
or if daily scraping for several days produces little change while interdental and tonsil tests are low, this pattern suggests other sources. A dentist or oral medicine specialist may evaluate for coated tongue secondary to medications, oral candidiasis, or systemic contributors. Expected timeline for improvement. Many people notice measurable change within 24-72 hours. More sustained shifts may continue over 1 to 2 weeks as bacterial communities rebalance. Periodontal pockets and gum disease. Signs and typical smell. Interdental or gum line origin odor that may be stronger on gauze or floss smell tests. Accompanying signs include bleeding on brushing or flossing, gum recession, pockets on probing, bad taste, and sometimes tooth mobility. The smell is often deeply unpleasant and persistent, with anaerobic character. Why it's persistent. Pockets create low oxygen niches where anaerobes thrive and are hard to reach with home tools alone. Home measures that help. Daily, thorough interdental cleaning, consistent toothbrushing with a fluoride toothpaste, use of a soft bristled brush to avoid trauma, and hydration. A water flosser may supplement cleaning but not replace professional therapy if pockets are deep. Professional care and thresholds. If gauze floss tests remain elevated after a conservative trial, or you have bleeding and clinical signs of periodontitis, schedule a dental appointment for periodontal probing and radiographs. A periodontist may recommend scaling and root planing, more frequent cleanings, local antimicrobials, or surgical options depending on severity. Home care supports clinical treatment but is not a substitute for therapy in established disease.
Expected timeline. Pocket and odor improvement after professional therapy can be seen within weeks to months, with a gradual reduction in VSCs as pocket depth decreases and maintenance cleansings occur. Restorations, crowns, bridges, and appliances. Signs and typical smell. Localized odor tied to a particular area or dental restoration. Detection often occurs where gauze or interdental testing yields strong smell near a crown margin, bridge connector, or beneath a removable denture. You might notice a trapped food sensation or recurrent bad taste around a restoration. Why it's important. Marginal gaps, microleakage, and poorly fitting prosthetics create persistent anaerobic niches that toothbrushes can't reach. Home measures that help. Meticulous interdental cleaning around restorations, soaking removable prostheses nightly and cleaning per manufacturer instructions, and avoiding adhesive overuse that can trap debris. For patients with partial dentures, remove and clean the appliance every morning and evening. Professional care and thresholds. Schedule a dental exam when odor is localized and persists despite careful home cleaning. The dentist will assess margins, occlusion, and fit. Treatment may include repair, recementation, new restorations, or adjustment of prosthetics. If restorations are the main contributor, timely correction can produce rapid improvements. Expected timeline. After restorative correction and professional cleaning, odor improvement can be notable in days to a few weeks as trapped biofilm is eliminated and margins are corrected. Tonsillar crypts and tonsilloliths. Signs and typical smell. A back of throat odor, post-nasal drip sensation, visible white or yellowish concretions on the tonsils, or a persistent foreign body sensation. Tonsil-related smell often seems to originate from deep in the throat rather than the mouth's front. Why they form. Crypts in the tonsils collect dead cells, mucus, and bacteria. Over time, this material can harden into stones. Chromic sinus drainage and postnasal drip increase the material available to collect in these crevices. Home measures that help. Gentle saline gargles twice daily, staying well hydrated, and avoiding aggressive self-removal techniques. Mechanical dislodgement at home with sharp instruments is unsafe. For accessible soft debris, careful gargling or a low-pressure oral irrigator directed away from deep tissue may help, but be cautious. Vigorous irrigation can push material deeper or cause irritation. Professional care and thresholds. If visible tonsilloliths are large, recurrent, or associated with throat pain, recurrent infections, significant halitosis unresponsive to conservative measures, or bleeding, refer to ENT. ENT evaluation may include a visual exam and flexible nasopharyngoscopy. Treatment options range from conservative removal in the clinic to, in very selected refractory cases, partial or full tonsillectomy.
ENT will weigh the impact on quality of life, frequency of recurrence, and risks of surgery. Expected timeline. Small tonsillar debris may respond to daily saline rinses within days. Recurrent or hard stones often require ENT management, and resolution after clinic removal or surgical intervention varies from immediate to several weeks during recovery. ENT and sinus-related contributors. Postnasal drip and chronic sinusitis are common non-oral sources of mouth odor.
The smell in these cases often has a postnasal character and may be accompanied by congestion, facial pressure, thick nasal discharge, loss of smell, or frequent throat clearing. Postnasal drip loads the oropharynx with mucus that can harbor bacteria and contribute to malodor. Home measures that may help: saline nasal irrigation, adequate hydration, and management of allergic triggers. Over-the-counter saline sprays and nasal irrigators can reduce mucus burden. However, if symptoms are chronic, purulent, or associated with systemic signs, an ENT evaluation is appropriate. ENT evaluation and tests. Clinicians may perform nasal endoscopy to visualize sinus drainage and mucosal inflammation. Imaging, such as a sinus CT, may be used in selected cases. ENT can recommend targeted therapies for chronic sinusitis, which may include medical management, topical steroids, saline irrigation, antibiotics in select circumstances guided by clinical findings, or procedural interventions in refractory disease. Systemic and metabolic causes. Several systemic states can alter breath in characteristic ways. Ketosis, seen with low-carbohydrate diets or fasting, often produces a fruity or acetone-like odor. Diabetes with poor glycemic control may also cause fruity breath and requires prompt PCP evaluation for metabolic control. Renal or hepatic failure can produce distinctive odors, ammonia-like or musty, and are accompanied by other systemic signs like fatigue, swelling, or changes in urine output. Medications and dry mouth. Many drugs reduce salivary flow: anticholinergics, certain antihypertensives, some psychotropics, and many over-the-counter agents. When dry mouth is prominent, morning breath often intensifies because saliva's cleansing action is diminished. If prescription medications are suspected contributors, document them in your log and discuss alternatives or medication strategies with your prescriber. Do not stop medications without medical advice. When to see your primary care clinician. Sudden onset of a distinctive fruity acetone smell, unexplained systemic symptoms, or significant changes in general health should prompt PCP evaluation. The PCP may order labs such as glucose A1C, basic metabolic panel, liver function tests, and others directed by the clinical picture. They'll also coordinate referrals to ENT or dental specialists when needed.
Diagnostic tests clinicians may use. Dental, periodontal probing and charting, dental radiographs to assess bone levels and hidden decay, restorative margin inspection, and evaluation of removable appliances. ENT, flexible nasopharyngoscopy to visualize sinuses and posterior pharynx, nasal endoscopy, culture or targeted imaging when indicated. Primary care, metabolic labs, A1C, basic metabolic panel, liver enzymes, when systemic causes are suspected, and targeted imaging if indicated. The clinician's scripts below are short, factual templates you can copy and paste or read aloud when making appointments. Keep the tone concise and clinical, and bring your log and photos. Dentist/general dental appointment script. Hello, I've had persistent bad breath for insert duration. I've been brushing twice daily and flossing, but my log shows ongoing odor localized to interdental sites. I completed a 48-hour trial of daily tongue scraping, saline rinses, and hydration with little change in interdental smell. Could you evaluate me for periodontal disease and check for issues around my crowns/bridges/dentures? Periodontist appointment script, if referred or self-requested. I'm seeing you because my dental provider identified persistent interdental odor and probing depths. I've been maintaining daily interdental cleaning and recorded my scores for 2 weeks without significant improvement. Could you assess pocket depths and discuss scaling/root planing and maintenance options? ENT appointment script. I have persistent back of throat odor and sometimes feel a lot of postnasal drip. I've tried saline gargles and logging my symptoms. There are visible white deposits at the back of my throat on some days. I'd like an ENT evaluation to rule out recurrent tonsilloliths or chronic sinus drainage. Primary care clinician script. I've noticed a new or persistent change in my breath that hasn't responded to thorough oral care over 2 weeks. My log notes a fruity or acetone smell occasionally and list any other symptoms like increased thirst, unexplained weight loss, fatigue. Could we check blood glucose/A1C and basic metabolic labs to rule out metabolic causes? What to bring to appointments. Your 2-week log or a summarized printout with daily morning breath scores, 3 check results, and notes on diet, travel, medications. Photos of tongue and throat if available, a list of current medications and supplements, including dose and start dates, any dental appliances you use, night guard, denture, or recent dental work records if you have them. Leah's vignette, an ENT pathway example. Leah is in her early 30s and has struggled with intermittent bad breath for over a year. Her tongue scraping produced only mild odor, and interdental checks were modest. Her primary complaint was a persistent back of throat smell and frequent clearing. She logged 2 weeks of saline gargles, respiratory humidity adjustments, and nightly neti pot use.
Her log showed little fluctuation. She also reported chronic nasal congestion and facial pressure. ENT evaluation revealed chronic sinus inflammation with posterior drainage. After a course of targeted topical nasal steroid therapy and ongoing saline irrigation, Leah reported significant reduction in back of throat odor within 3 weeks. Her log showed consistent lower morning scores, and she avoided unnecessary invasive procedures because documentation guided appropriate conservative ENT treatment. Leah's case underscores how non-oral sources can dominate and how targeted specialty care, guided by disciplined self-monitoring, leads to efficient solutions. Red flags that require urgent evaluation. Sudden breath change with systemic symptoms, fever, rapid weight loss, night sweats, difficulty breathing, swallowing, or severe throat pain, heavy bleeding from the mouth or throat that does not stop with gentle pressure, a rapidly enlarging neck mass, or significant unilateral ear pain with no clear cause, persistent fruity acetone odor accompanied by extreme thirst, frequent urination, confusion, or fainting. Seek urgent medical attention. If any of these appear, go to urgent care or emergency services and bring your log if possible. Practical troubleshooting and common FAQs. Question: I have braces. Is tongue scraping safe? Yes, generally. Use a flexible, non-abrasive scraper and make short, controlled strokes. Work around brackets and wires carefully. Do not pry at hardware. If you have a fixed lingual bar or bonded retainer, use a toothbrush to gently brush the tongue after scraping, rather than pressing the scraper into tight spaces. Question: can mouthwash alone fix this? Mouthwash can temporarily mask odor and help reduce surface bacteria, but it rarely resolves sources like deep periodontal pockets or tonsillar crypts. Prefer alcohol-free rinses if used regularly, and reserve stronger antiseptic rinses such as clohexidine for short courses under clinician direction. Question: how often should I replace my tongue scraper and toothbrush? Replace a toothbrush every 3 months or when bristles fray. Tongue scrapers should be replaced when they show wear, rough edges, or difficulty cleaning, typically every few months for plastic scrapers and according to manufacturer guidance for metal scrapers. Sanitize the scraper by rinsing and allowing it to air dry after use. Question: is it okay to use a baking soda rinse instead of salt? Baking soda, sodium bicarbonate, can be used occasionally to neutralize odors and acidity. If you have a sodium-restricted diet or medical condition, consult your clinician before daily use. Saltwater rinses are generally gentler for frequent use. Question: are probiotics helpful for bad breath? There is emerging research suggesting certain oral probiotics may shift the oral microbiome and reduce malodor in some people. Evidence is still evolving, and probiotics are adjuncts rather than first-line therapy.
Discuss with your dentist if you're considering a probiotic product. Q. What about toothpastes for bad breath specifically? Toothpastes that contain ingredients to reduce bacterial load and neutralize odors can be helpful as part of a broader routine. Focus first on mechanical cleaning and interdental hygiene. Toothpaste is supportive. If you have sensitive teeth or taste issues, select a formulation appropriate for those needs. Q. How long before I should expect results? Tongue-related odor often shows noticeable improvement within 24 to 72 hours of consistent scraping and hydration. Interdental and periodontal issues typically require weeks and professional therapy for substantial change. Tonsil and ENT-related problems vary widely. Some respond in days to saline and topical therapies. Recurrent tonsilliths may require ENT intervention and follow-up. Myth versus fact. Quick clarifications. Myth: bad breath always means poor hygiene. Fact: while hygiene is a major factor, many contributors, tonsils, sinus drainage, systemic disease, medications, and dental restorations, can cause odor despite careful brushing and flossing. Myth: alcohol mouthwashes are best because they kill more bacteria. Fact: alcohol-based rinses can temporarily reduce bacteria, but may dry the mouth and worsen odorous conditions for some people. Alcohol-free antiseptic formulations are often preferable for routine use. Myth: tongue scraping damages taste buds. Fact: gentle scraping removes debris without damaging taste buds. Excessive force or sharp instruments can injure tissues and should be avoided. Safety and practice caveats. Never use sharp objects, toothpicks, needles, or other pointed instruments to remove tonsil stones or throat debris. If you experience new pain, bleeding, or altered taste after introducing a habit, pause and consult a clinician. Do not stop essential prescription medications because of breath concerns. Instead, document and discuss with your prescriber. Avoid prolonged high-frequency use of potent antiseptic mouthwashes unless under clinician supervision due to risks of staining, taste alteration, and microbial HIFs. A practical, clinician-friendly documentation template you can copy into notes or print. Date: morning breath score 1 to 10, tongue scrape score 1 to 10, floss gauze rating 1 to 10, tonsil visual, none, soft debris, stones. Habits completed: water, scrape, saline, brush, floss, xylitol. Foods prior evening, new meds or changes. Photos attached, yes, no. Notes. Example entry. 2025-0603, 7, 8, 6, soft debris. Water, scrape, saline, brush, floss, gum. Garlic dinner, none. Yes, notice more gagging during scraping. Bring a printed or digital copy of this summary to dental, ENT, or PCP appointments. It saves time and focuses the visit on targeted assessment.
How clinicians often proceed after receiving a solid log. Dentists will typically perform a clinical exam, periodontal probing, and bite wing periapical radiographs to look for pockets, bone loss, restorative margins, or decay. Periodontists focus on probing depths, full mouth charting, and staging the disease to recommend scaling/root planing and maintenance intervals. ENTs will visually inspect the nasopharynx and oropharynx, often using a flexible scope in clinic, and may order sinus CT if chronic sinus disease is suspected. Primary care physicians will tailor labs to symptoms: A1C for suspected diabetes, basic metabolic panel for renal concerns, and liver function tests if hepatic disease is in the differential. Final practical checklist before leaving this video. Start the 5 morning habits today: water on waking, gentle tongue scraping, saltwater gargle, thorough interdental cleaning, and the morning inspection/logging ritual. Run the 48-hour diagnostic trial exactly as described and record your results. Extend the routine to 2 weeks and summarize trends. If interdental or restorative odor persists, schedule a dental appointment with your log. If throat or sinus-related odor persists, schedule an ENT visit. If systemic signs or distinctive metabolic breath are present, see your PCP. Avoid sharp tools and aggressive removal techniques for tonsil debris. Use saline and seek ENT care for recurrent or symptomatic stones. Use alcohol-free mouthwashes short-term if needed, and consult your clinician before beginning long-term antiseptic regimens. To close, these 5 morning habits are designed to be simple, safe, and informative. They reduce the most common, treatable causes of morning breath and give you a structured way to learn what's working and what isn't. Keep the log. It's the single most valuable item you can bring to a clinician. If you follow the routine and still have persistent high scores after 2 weeks, bring the documentation to the appropriate specialist, dentist, periodontist, ENT, or your primary care clinician, and use the scripts provided to make the visit efficient. If you found this guidance helpful, the hands-on technique demo linked in the description shows exact scraper positioning, interdental brush sizing, and the saline gargle technique in real time. Watch that next for practical visuals. If your breath problem persists despite these steps, or you notice any red flag symptoms, please schedule professional evaluation. With patience, targeted action, and good documentation, most causes of bad breath can be identified and managed effectively.